let folks in. I know there will be more that are joining as well. Good morning, everyone. Thank you so much for being here. My name is Sydney Carter. I'm the Policy Program and Special Projects Manager at NBHP. I thank you for being here. I'm really excited to introduce our October continuing education event, Behavioral Treatments for Substance Use Disorders During Pregnancy, with Dr. Abby Candelari from Baylor College of Medicine. She's an assistant professor in the Department of Psychiatry and Behavioral Sciences, and she has affiliation with Baylor College of Medicine as well as Harris Health System and within that Ben Taub General Hospital. And so I will ask you all to stay muted unless Dr. Candelari asks you to come off. Please put any questions in the chat. And then for CE information, 1 hour is available today to LMFTs, LPCs, LCDCs, CHWs, licensed psychologists, peer support specialists, and licensed, I'll put it in the chat. I think I got everything. There's 7 specialties. And to be eligible for that, you have to join this by 10:15 a.m. So you all are good and stay for the duration, as well as take the survey that will be placed in the chat at the end. So thank you all so much again. And without further ado, I'll pass off to Dr. Candelari. Thank you so much.
Great. Thank you so much, Sydney. I'm so excited to be here today. Like Sydney said, I'm an assistant professor at Baylor College of Medicine. I'm a licensed psychologist. I did my training at the University of Houston and then my residency and fellowship with Baylor College of Medicine. And after completing my training with Baylor College of Medicine, I moved on. I'm still affiliated with Baylor, but I now work at Harris Health at Ben Taub Hospital. And I am the primary clinical psychologist in a clinic called the Maternal Perinatal Addiction Treatment Clinic. So today I'm going to be giving lots of information on the evidence-based behavioral treatments for substance use disorders during pregnancy that I use in the clinic that I work in. And then I'll also be sharing a little bit of information about just substance use in pregnancy, what the data is showing, and then a little bit about a grant that we have going on at Harris Health and the goals of that. So the presentation objectives include to review background information on substance use during pregnancy, describe the multidisciplinary clinic that I work in at Harris Health, optimize to treat pregnant people with substance use disorder. We're going to be reviewing evidence-based behavioral treatments for substance use disorders, and also talk about considerations for working with individuals during pregnancy. So specifically, the treatments we're going to be reviewing are CBT for substance use disorder with really a focus on like a couple of skills within CBT that are most helpful for SUD. We're going to be talking about motivational interviewing. That is actually like the bulk of this presentation. Motivational interviewing is great because it can really be incorporated into medical settings, primary care, other just types of settings. And so it's like a communication style that no matter, I think, no matter what type of patients you're working with, you can kind of like adapt it and incorporate it. So we're going to be going over motivational interviewing a lot. And then I'll also be touching on DBT and ways that it can be incorporated. DBT is, of course, traditionally a very long and structured type of therapy. And so in our clinic, we're seeing pregnant women with substance use disorders. It's typically either before or after their OB visits. And we also never know exactly how many visits we're going to get to see individuals for. And so instead of doing like full DBT, we really just kind of use like certain skills of it. So I'll be touching on the skills that can be incorporated when working with individuals with substance use disorder. A couple of notes on the words that we should use when talking about individuals being treated for substance use disorder. The main point is just using person first language. So person with SUD versus addict. We also want to minimize using words like abuse, just because the research has shown that it's associated with negative judgments. Also, talking more about words The words clean and dirty are not medically accurate and can also lead to stigma. So a better alternative is testing positive or testing negative. And then finally, when we're talking about the babies born to these women, we need to remember that addiction refers to a behavioral disorder. So therefore, babies who have just been born cannot be addicted. Instead, they are simply born manifesting a withdrawal symptom. Now we're going to go over some background information on SUD and pregnancy. So we know that substance use disorders during pregnancy are associated with a variety of complications. When SUD is left untreated, the consequences are even more severe. Lack of prenatal care, fetal growth restriction, preterm labor, also violence and sometimes legal consequences. These are common risks and things that we do see in our clinic quite a lot. Okay, the main data to highlight here in this slide is that on average, getting pregnant does reduce substance use, and the use tends to decrease by trimester. There are large reductions in illicit drug and alcohol use once someone finds out they are pregnant. However, we do want to highlight that the nicotine use actually decreases less, particularly in that last trimester. And this slide is important because this is one of the main areas we are seeking to improve with our maternal opioid misuse grant, the grant that I mentioned that I'll be speaking about a little bit. So the idea here is that traditionally Medicaid expires 60 days after delivery. So all pregnant women in Texas are okay, if everyone can just make, oh, perfect. Okay, yeah, just make sure you're muted. Um, okay, so all pregnant women in Texas are eligible for Medicaid. However, it traditionally expires 60 days after delivery. And we see that this is actually correlated with increase in maternal death after 60 days. Most of these deaths are preventable. Reducing maternal mortality is one of the overarching goals of our grant. This data is highlighting that after 2013, opioid use disorder rates have continued to increase, and now opioid drug overdose is the main cause of maternal death in the postpartum period. Here highlighted in red, you can see that the late postpartum period, so over 60 days postpartum, is when women are at the highest risk of overdose-related death. And so again, we're seeing that Medicaid expires, and right around that time, the risk of mortality is going up. So one of the overarching aims of our maternal opioid misuse grant is to expand Medicaid coverage. So that was a little bit of the background information. Now I'm going to go over the treatments that I offer that are evidence-based for substance use. So here we're going to be focusing a little bit more on opioid use disorder. However, the interventions that I'm going to describe are also quite relevant for all substance use disorders. Okay, so most evidence suggests that medications, also known as medication for opioid use disorder, combined with behavioral therapy results in the best treatment outcomes for opioid use disorder in particular. But interestingly, we really do find throughout the psychiatric research that when you combine medications plus therapy, it really results in the best outcomes pretty much like across the board. And I think this makes sense if you think about it, because the medication component, that psychiatric management is critical. And then when you combine it with personalized behavioral treatment, it improves the outcomes. So alone, evidence for behavioral therapy for opioid use disorder is mixed. The medication-assisted treatment is currently the gold standard, but again, like I just said, research shows that using cognitive behavioral therapy skills can enhance engagement in treatment. It helps people learn how to cope with urges to use opioids, and it can help them develop healthier coping strategies. So now I'm going to talk about the therapeutic approaches that I use when I'm working with pregnant women with substance use disorder. And of course, the first step is always the clinical interview, getting to know that individual. So I really just do a standard clinical interview, probably like many of you guys already know how to do. I think when you're working with somebody who has substance use disorder, of course, there's just a bit of extra emphasis on substance use history. social history and social support. And then when you're working with a pregnant individual with substance use disorder, I also focus a lot on evaluating where they stand with the pregnancy, including their attitude towards the pregnancy. So a question that I often ask is, what was it like finding out you were pregnant? And seeing just, again, their attitude towards being pregnant and their ideas on parenting. And then in our clinic, we are also lucky to offer psychology services to inpatient women. So oftentimes we'll have women come to start the medication for opioid use disorder, and I can actually go see them while they're inpatient at the hospital. So sometimes this first initial interaction occurs inpatient, and then they follow up outpatient in our maternal perinatal clinic. Okay, so now I'm going to be going over some of the therapeutic approaches that are helpful for working with SUD, and then also just kind of like the particular techniques that are most relevant to SUD. Cognitive behavioral therapy, of course, is traditionally the gold standard for anxiety, depression, and then there are aspects of it that are really, really helpful with substance use as well. DBT focuses on emotion regulation, mindfulness, and interpersonal effectiveness, and we'll kind of talk about some of these aspects apply to substance use. And then motivational interviewing is traditionally known as the gold standard for substance use. I mentioned this at the beginning of the presentation, but another thing I really like about motivational interviewing is that it can really be incorporated into other conversations. So again, I feel like the motivational interviewing is kind of like, it can be flexible. And I think that's another reason it's so helpful. Okay, so CBT is, of course, a form of psychotherapy that focuses on the interrelation between thoughts, feelings, and behaviors. This graphic is, of course, the CBT triangle. So really explaining this graphic to patients is one of the first steps in psychoeducation in a traditional CBT protocol. CBT examines how our thoughts, feelings, and behaviors interact to shape our perception and emotional and behavioral responses to the environment. So once individuals better understand these patterns, they are better able to be prepared with coping skills and are also more effectively able to anticipate triggers. So just a note, when I'm starting a CBT protocol, I really do like to emphasize tracking, and sometimes this is not really fun for people. They're kind of like, why are you making me track? Like, I don't want to. And so I really just emphasize, like, if we are going to be changing some of these components, we really need to understand how they work. So the CBT helps patients identify negative patterns of thinking and maladaptive behavior patterns and incorporates effective coping skills. And then for substance use in particular, CBT can actually help people cope with the physical withdrawal symptoms using PMR, mindfulness, behavior chain analysis, and more. And then within cognitive behavioral therapy, Lent et al. 2021 found that the following were most relevant for treating those with opioid use disorder: coping skills, planning for relapse prevention, and then, of course, that therapeutic alliance and rapport. Okay, so behavioral and emotional patterns are important in the development and maintenance of opioid use disorders, as well as all substance use disorders. So importantly, the therapist will help the patient identify antecedents to and consequences of substance use. The therapist will also help the patient identify physical, emotional, or cognitive triggers to substance use. So for example, thinking about a certain topic, being triggered with a certain person, experiencing certain thought patterns. Awareness of these triggers is crucial to developing effective coping strategies and being prepared with and ready to use these coping strategies in advance of actually being triggered. So one technique that I love to use is behavior chain analysis. So in behavior chain analysis in CBT, the therapist and the patient work together to identify cognitive, physical, and emotional triggers to opioid or other substance urges. The short and long-term impacts are identified and discussed. We also discuss the vulnerability factors in prompting events. And then this helps the patient prepare for the next time they're in that situation. So this, again, shows behavior chain analysis, asking the person, what factors made you feel vulnerable? What was the event that prompted the chain? What thoughts went through your head? What were you feeling in your body? What feelings were you having? How did it impact you in the moment, and how did it impact you in the longer term? And then finally, what was the final outcome? Another technique that is really helpful and relevant in treating substance use disorders within CBT is relapse prevention planning. So, a relapse prevention plan should include identifying warning signs that a lapse or relapse may be coming. Again, these can be physical or emotional, and they, of course, differ by the individual. Always signs to ask for help. So, especially if you're like about to terminate with someone, talking in detail about what are some signs that you may need to contact me to schedule again. And then plan of action, including coping skills, social support. The therapist and the patient agree on the plan, and the patient feels that it is doable. So just like a safety plan, a relapse prevention plan is only helpful if it's doable and the patient agrees that it's doable and agrees to use it. So this is just closer up, a helpful template that I sometimes use. So first we go over the identified triggers, next review adaptive coping skills, next identify social supports. And then another thing I like to do too, I do this with safety plans as well as relapse prevention plans. Under social support, where it says the 3 people you can talk to, I actually like to write down their phone numbers. And I feel like that just gives it an extra sense of, okay, so like, even if all your contacts are deleted, even if your phone gets stolen, even like no matter what happens, here are these people's phone numbers, and you have this printed out copy of your safety plan or relapse prevention plan. I was just going to highlight within the maternal perinatal addiction treatment clinic that I work in at Bentob, there is a ton of history of trauma. And there are some aspects of CBT that can be very invalidating for populations who've experienced trauma, systematic oppression, aggression, racism, things like this. And the reason is because CBT does have a really big focus on changing thought patterns. And sometimes when you've experienced racism, trauma, things like this, it's not necessarily how you're thinking about it. It actually is like what you went through. And so when working with populations who have experienced trauma, it can sometimes be more helpful to focus more on like the behavioral aspects of CBT versus the cognitive. And again, I still use CBT all the time. I just try to be respectful of the histories of trauma that our patients endorse. Okay, so there are some really useful DBT skills to incorporate when treating SUD. This treatment was created by Marsha Linehan to treat suicidality and oftentimes people with borderline personality disorder, and has a really big focus on treating behavioral and emotional dysregulation. This treatment is typically very long, structured, very focused. Within our clinic, we actually don't really have the capacity to do like a full DBT program simply because we're kind of meeting these patients where they're at. We never know how many times we're going to see them. We have very high no-show rates, and also sometimes very high rates of like people not coming back. So you just never exactly know like how long you're going to be seeing these people for. But many of them do have history of suicidality and sometimes active suicidality, and would benefit from some like emotion regulation techniques. So we do try to incorporate some of like the DBT like shorter skills when possible. Okay, so DBT assumes that people are doing the best that they possibly can in their current situation. Problems are not always one person's fault, but it is their duty to try to resolve it. It also assumes that there are at least 2 ways to solve any problem. It assumes that people generally want their situation to improve, and it assumes that everyone is capable of learning new behaviors that can change their lives. And then DBT also states that change is the only constant and helps people to kind of embrace change in a different way. I'm just going to briefly go over some of the core principles of DBT and how they relate to substance use. Mindfulness helps individuals become more aware of triggers, cravings, and automatic behaviors associated with substance use. Improving distress tolerance improves the ability to manage cravings or overwhelming emotions, reducing the urge to use substances as an escape. Emotion regulation skills focus on understanding, labeling, and changing emotional responses. And so therefore, these skills can help us gain control over impulsive behavior driven by emotional distress. And then interpersonal effectiveness helps individuals communicate more effectively, set boundaries, and build healthier relationships. I wanted to also note that um, in the population I work with, oftentimes I am seeing a woman who has decided to enter residential treatment for substance use disorder. And we actually have a formal partnership with Santa Maria Hospital, which is a treatment facility for substance use disorder for women in particular. Um, and so anyway, so oftentimes interpersonal effectiveness comes up because one of the really overwhelming aspects of entering residential treatment for substance use for the first time is entering a group setting. So they're now living in this group setting for the first time, and they've also just made this huge decision that they're entering substance use recovery. And so the interpersonal effectiveness strategies can be really helpful for just like improving day-to-day interactions. The interpersonal effectiveness also comes up frequently when a family member or partner is still using, and we'd have to discuss with the patient how to set boundaries and maintain safety. Okay, so now we're going to review motivational interviewing, or MI, in the context of substance use disorder, which is the bulk of the slides today. Motivational interviewing is a type of behavioral treatment best described as a style of communication aimed at eliciting change and planning for change. So again, I've said this already in this presentation, but it can be incorporated as like a style of communication in medical settings. So in our maternal perinatal clinic, I give our patients extra support, and I give them like very like heavy motivational interviewing, but the physicians in this clinic are also trained in MI, and they can incorporate it while they're evaluating patients. So MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. It is a clinical method, a guiding process that seeks to bring forth and strengthen a person's own motivation for change. It is patient-centered in that it is collaborative and fully respectful of the patient's autonomy and preferences. The use of MI principles and practices helps people sort through their thoughts, ideas, and oftentimes ambivalent feelings about their current situation and possibilities for change. And then it's widely used in addressing substance use disorders, and it's also actually been found to be effective in other clinical settings as well. So it can actually really be helpful for making any type of behavioral change. So sometimes people use it for like weight loss or like improving dental hygiene. You can really use motivational interviewing if you're just trying to make any type of behavioral change. Okay, so it's a style of communication used in behavioral therapy. It focuses on empowering people to move towards change while honoring autonomy. It focuses on emphasizing the patient's own reasons for change rather than forcing or persuading them to follow an expert's advice. It was developed in the 1980s by two psychologists, Miller and Rolnick, and it was originally developed for alcohol use disorder. Motivational interviewing assumes that individuals with substance use disorders or individuals who are contemplating any type of change really lie on a continuum of readiness for change. So patients may be in pre-contemplation or contemplation when behavioral treatment is initiated. It is our job to determine where the patient lies on this continuum, engage that patient in change talk with this in mind, and then also helping our patients work towards the preparation, action, and maintenance stages. But if we assume that a patient is already in one of these stages, that is actually doing them a disservice and may hinder progress and can also hinder buy-in to treatment. Motivational interviewing explores the patient's interest in change rather than assuming that they know they should change and have already decided that they want to change. MI assesses reasons for ambivalence. It is also important to not assume that people who are ambivalent are unmotivated. Better understanding an individual's ambivalence will help them to move to the next stage of change. Motivational interviewing elicits and encourages change talk. It then develops a plan for change. It empowers patients to feel confident, and it acknowledges incremental successes, which is crucial since the progress is not always linear when you're working with substance use. How does MI accomplish this? So it keeps the following qualities in mind. First, it is client-centered. It encourages the patient to engage in self-reflection. It helps patients take consideration of what was helpful to past changes. It increases a person's discussion of the change itself. And then importantly, it avoids parenting or advising that may increase defensiveness. So a note on our approach in the maternal perinatal addiction treatment clinic that I work in. I just wanted to like make a note that our goal definitely is to help the pregnant moms coming through our clinic to stop using substances as soon as possible. That is like 100% our goal. But the research shows that if you simply tell patients how bad, how destructive, how damaging this is, it will actually build resistance. So the idea here is that most people with substance use disorder already know that using substances has risks, including risks of pregnancy. So they already know this. Substance use is much more complex than this, right? It requires thoroughly understanding a person's background, behavioral patterns, and motivations for using. The other thing I see a lot in our clinic is again, I already highlighted that huge trauma history. So people kind of self-medicating with substances to deal with their trauma. And then also big family history of substance use. So I've had countless women in my clinic tell me that they were first given substances by their parent. And so if you just think about that, like it's not only like one behavior, it's a behavior in a context of all of these other risk factors, all of these other like social contexts. And so again, motivational interviewing just really assumes that you need to thoroughly understand that instead of just telling people, listen, this is really risky, like stop doing it. And again, the research also shows that if you just tell people, stop doing this, it's really risky, then it doesn't work. So now we're going to review rule in motivational interviewing, which helps us accomplish better communication and work more effectively with our patients with SUD. R stands for resist. Resist the righting reflex. In other words, resist urges to tell patients what they should and should not do. U stands for understand motivations. The clinician should thoroughly understand a patient's motivations for their behaviors and encourage collaboration instead of pushback. L stands for listen empathetically. The clinician must listen to develop a shared understanding of the patient's problem. And then E stands for empower and encourage. So this leads to change talk and elicits reasons for change, which is the heart of MI. Some more on MI strategies. These are some more of the core principles developed by Miller and Rolnick. They are express empathy, support patient self-efficacy, develop discrepancy, and roll with resistance. People can tell when you are really listening and when you try to see the world through their eyes. So creating an open and welcoming space to discuss concerns, expressing empathy verbally. So saying things like, this is hard, I can understand. Also just think for a minute about these two phrases. No thoughts about killing yourself recently, right? Versus sometimes when we feel trapped in our situation or overwhelmed by what's happening in our life, we can have thoughts about hurting or killing ourselves in order to escape all of the worries. Have you had thoughts like this recently? So again, this slide is really highlighting trying to see the world through our patient's eyes and really showing that we're listening. More ways to express empathy and ways to kind of like improve communication in line with MI. So imagine saying, you know that is bad for your baby versus I hear you. You are not sure if making a change is possible right now. Rather than we aren't here to judge your decisions, kind of reflecting back. You feel the only way to cope is with alcohol. Developing discrepancy involves building a picture of the way things currently are for the client, and then building a picture of the way they would like things to be, and highlighting, are the behaviors that you're currently doing aligned with the way you want things to be? This helps a person get unstuck from their ambivalent feelings that keeps them in the same behavior patterns, helps the patient determine how important a change could be, and it's most helpful if the patient talks about the reasons for change rather than the provider. Here are some examples of developing discrepancy. If you continue to use drugs during the pregnancy, you are going to harm your baby. Imagine saying, if you were to continue using drugs during the pregnancy, what is the worst possible scenario in your mind or the best possible scenario? And then imagine saying, it sounds like you should stop going out to the bar every night, versus saying, on the one hand, you want to go to the bar every night. On the other hand, you told me how going to the bar every night gets in the way of you spending time with your son. A note on resistance. Opposing resistance generally reinforces it. Resistance is a signal for you to respond differently as the clinician. Some things to look out for: arguing, interrupting, negating, or denial and ignoring. Resistance can actually be reframed as a new momentum towards change. So here are some examples of rolling with that resistance. You just don't get it. Easy for you to say. You say, I am listening, but maybe I really don't get it. Help me see your perspective. Imagine that they say, I can't stop using right now unless I get enough benzos. You say, whoa, whoa, you're way ahead of me. Let's go back to how your substance use fits or does not fit into your life goals. And then also supporting self-efficacy. So try to increase self-efficacy by supporting patients' efforts, focusing on past successes, building on available skills, and eliciting and supporting hope. And then another note is during my work with the patients in the maternal perinatal addiction treatment clinic, it's not always their first time attempting recovery. So it can be very helpful to talk in detail about what were past recovery experiences like for you and how does this one feel different. Okay, so now we are going to go over OARS, which stands for open-ended questions, affirmations, reflective listening, and summaries or summarize. So these skills are critical in actually implementing the motivational interviewing, and it can be really helpful when you're first beginning to actually try to keep track, like either tally, very like secretly tally or mentally tally how many of these skills you are using. Okay, so O stands for open-ended questions. Try to ask questions that can't be answered with yes or no. This allows the client to explore their thoughts in greater detail. So asking things like, are there good things about using substances? Are there bad things about using? Tell me more about this. What has been going on since the last time we met? What was, a certain situation like for you? What's different this time? More helpful open-ended questions, asking what sorts of things are important to you? What are your values? What would happen if you don't change? What would your life be like if you stop? And then what may happen if things continue as they are? So you can do more kind of asking about how they see the world, what are their values, and then also how do they perceive how things are going right now, and how do they want things to be going with the open-ended questions. Affirmations are super important. They are statements that recognize and encourage a person's strengths, recognize the strength that it takes to attend a therapy session. Also, again, with the clinic that I work at Bentall, where it's the maternal perinatal addiction treatment clinic, it can be really stressful because they know that, first of all, they're having to travel all the way to the medical center, and then they're having their OB visit. They know they're going to get that urine drug screen. They know that they're going to see social work. They know they're going to see me. It takes a lot of strength to simply attend. And so recognizing that. So saying things like, thank you for coming today. Clearly you are strong, capable, resourceful, motivated person to have coped with these difficulties. I appreciate your willingness to talk. It takes strength to discuss this with me today. R stands for reflective listening. So I also like to describe it as like active and reflective listening. It involves responding to the patient in a way that makes it clear that you care and that you've been listening carefully. This allows the listener to demonstrate empathy by demonstrating their understanding of the world through the patient's eyes. The patient can then correct the provider if needed, furthering the rapport and furthering the patient's feeling of being understood. Reflections are statements intended to mirror meaning of the patient's report, seeks to understand the person's subjective experience, offering reflections as guesses about the person's meaning. and then checking rather than assuming you know what is meant, listening not only to what the person says, but also for what the person means. So again, this requires attempting to interpret what they say and checking for confirmation. When you're doing reflections, try to avoid judging, criticizing, or blaming. Create an environment of unconditional positive regard and acceptance, even if this goes against the status quo or societal norms. Reflections tell the person you are interested in understanding the world from their eyes, and it involves an acknowledgement of the person's disagreement or ambivalence, feelings, or perceptions. Here are a couple of examples of reflections. On the one hand, it sounds like using opioids has created some challenges for you. And yet, on the other hand, there are also challenges with stopping. Okay, so now I'm going to be going over summaries. The summaries allow the clinician to recap the discussion. The summary may highlight strengths and reasons for change, as well as barriers to change that have been discussed. Here's a good example of a summary. It sounds like you are concerned about your opioid use because it has created some financial problems and has started to cause some issues with your family. You also said quitting will probably mean changing who you spend most of your time with each day. That doesn't sound like an easy choice. Okay, and then for the last portion of today's talk, I'm going to quickly go over like the services that are offered by our maternal perinatal addiction treatment clinic and just talk a little bit more about like our clinic for a few slides, and then we'll have some opportunities for questions. So with our clinic at Bentob, it is a highly multidisciplinary team. We have OB providers, anesthesiology, neonatology, psychiatry, psychology, that's me, social work, and then all of our nurses have training in working with our population. So our clinic runs on Wednesdays and Fridays, and when they come, again, they have access to all of these different services. So the OBs will kind of make referrals for psychology for like people who need extra support, like would benefit from seeing psychology. And then they're also offered social work. They have a consultation with anesthesiology before they deliver too. So again, a very unique, very multidisciplinary clinic. Some of our program goals, strengthen the community partnerships, supporting structures and communication between common organizations that interact with pregnant women with SUD. So we do a lot of community outreach. We've worked with like Legacy, different medical schools in the area, strengthening community partnerships. And then we also have a formal partnership with Santa Maria Hospital, which is an inpatient recovery facility for women. And then assist the prenatal community in Houston with screening, brief intervention, and referral to treatment, and safe pain prescribing practices. Creating centralized multidisciplinary care model within Harris Health at Bentob to care for pregnant people with SCD. Of course, that's our MPAC clinic. And then redesign Medicaid programs to support pregnant women with opioid use disorder. Okay, and then our maternal opioid misuse grant. This is a collaborative grant with the Center for Medicare and Medicaid Innovation Center. It addresses serious limitations in the care of pregnant and postpartum patients with Medicaid who have opioid use disorder. I'm talking about those limitations with it expiring 60 days postpartum and the huge issues with that. That's a time where women are very vulnerable. And then when you have their Medicaid expire at the same time where they're feeling very vulnerable, it creates huge detrimental consequences. Our grant also aims to achieve this through state-driven transformation of the delivery system surrounding this vulnerable population. And now I would like to open it up for any questions. And then my very last slide, I also have some information on referrals. If anybody does come across a pregnant individual and they disclose to you that they have substance use, this is some contact information for referrals.
Anyone have any questions? I see some kind of introductions in the chat. Someone did ask if the slides are going to be available. The recording, yes, will be available on our NBHP website. So I'll make sure to send out that link after the event, probably tomorrow. So yes, we will have the recording available. Anyone have any questions? Feel free to put something in the chat or come off mute. Susie said, I'm a social worker at Legacy Community Health. Can I refer patients to your program if they're receiving OB care at Legacy?
Absolutely, yeah. So we did a legacy talk really recently. We work very closely with you guys, and we've actually had lots of referrals from legacy.
Perfect. And I said earlier, Santa Maria Hospital is a member with NBHP, and so we work with them a lot. And so it's really neat to see the the cross partnerships everywhere. And um, let's see. Kara asked, are patients receptive to being connected with psychology during their hospital stay?
Yeah, so this is actually something we've been working on improving. The clinic that we have on Wednesdays and Fridays, it can be kind of hectic. And so what I've started to find is that as soon as I'm notified that there's somebody being admitted inpatient to initiate their medication for opioid use disorder, I try to go introduce myself in that inpatient setting. And then they typically have their outpatient OB visits, like their ultrasound, like OB checkups, all of that. And then I'll see them on those days as well. And then typically sometimes patients are admitted again inpatient if they have like preeclampsia, like they have a complication, and I can go see them then too. But then typically after they initiate the medication for opioid use disorder, typically the next inpatient stay is the delivery. And so typically I go see them after delivery.
Great. And there's another question from Susie. Is it only for opioid use disorder or other SUDs?
Okay, so I'm assuming that's asking about like our referrals in our program. So our clinic sees all substance use disorders, but we have grant funding for the opioid use disorder. We can still like we have social work people who can, if there's coverage problems, like the answer is like we can see people with any substance use disorder, and we have social workers to help with coverage if that's an issue. And then in terms of, I want to answer that too for the treatments. So the motivational interviewing was developed for alcohol use disorder, but they've actually used it with different substance use disorders as well as like other behavioral changes, like I mentioned. So really the interventions I mentioned today are relevant to all substance use disorders.
Very good questions. Are there any others? Again, feel free to place in the chat or come off mute. Well, I'll still give people a couple minutes, but I can kind of mention my wrap up CE information in case anyone has a question and is kind of formulating it. So again, thank you all. I placed some information in the chat at the beginning and then around in the middle to remind you all that 1 hour of CE training was available today, as long as you joined by 10:15 and stayed for the duration, as well as take the survey link that I'm about to place in the chat by 12 o'clock tomorrow, Thursday, October 3rd. And our credits available to LMFTs, licensed psychologists, licensed social workers, CHWs, LCDCs, LPCs, and peer support specialists. And CE certificates cannot be distributed if these criteria are not met. Thank you for understanding. And the certificates will be distributed within 1 week. Thank you for that. It is just me doing this. So thank you. And the slides and recording, again, will be available after the event. And as you can see, Dr. Candelari's information is here on the screen if you have other questions to follow up with her. And so in that time, I did not see anyone else say anything about a question or comment. And so I just placed the survey link in the chat. Please make sure to take that by 12 o'clock tomorrow if you'd like that CE credit. And aside from that, thank you all so much for coming today. I really appreciate you being here, and thank you so much to you, Dr. Candelari, for presenting. And I learned a lot. I always kind of say I'm not a clinician, and so I always learn a lot from these trainings in a slightly different lens, where my work would be more kind of advocacy or legislative policy focused. And so I always love being in these spaces and just really appreciate your expertise and time and training with us. And so thank you all so much for joining. And without anything else, we'll stay on for a couple minutes, but feel free to exit and we'll be here for a couple minutes if anyone has anything else. So thank you. So I'll end this.